Welcome to the Dr. Mary Louder podcast show, where we explore the messy, magical, and deeply human journey of healing. I'm your host, Dr. Mary Louder, a board-certified osteopathic physician, an accidental shaman, and a lifelong student of the human experience. Together, we're going to talk medicine, wellness, and culture in a way that's grounded, perhaps maybe a bit cheeky, but always from the heart. And don't miss Gadgets, Gimmicks, and Gotchas, my reoccurring segment where we lovingly call out the fluff and highlight the stuff that actually works. So grab your favorite brew, coffee, matcha, or that mysteriously green smoothie and settle in. It's time to get this party started with a strong dose of soul medicine. Welcome to the Dr. Mary Louder podcast, where we gather to explore healing, story, and soul. I'm glad you're here. Today's episode is for anyone who's ever felt like they were doing everything right on paper, but still not getting the answers they need. I'm joined today by Dr. Grace Charles, who's a naturopathic physician specializing in holistic fertility care. Together, we're going to impact what often gets missed in conventional fertility workups and how root cause integrative approaches can offer so much more than just lab results. We explore the emotional, the spiritual, and lifestyle factors that impact fertility. We're going to look at how naturopathic care addresses the why behind hormonal imbalances and what true partnership in fertility care can look and feel like. So if you or someone you love is navigating the tender terrain of trying to conceive, this conversation is full of insight, compassion, and hope. Welcome, Dr. Charles, and let's get into the conversation. Well, welcome, Dr. Charles. Dr. Louder here. Let's just drop the formalities and go by Grace and Mary. How's that?
Mary, it's great to be here. This is fun.
It is, and you're in Steamboat Springs, which is beautiful, and I used to live in Boulder, which is beautiful, and so, now I live on the east shore of Lake Michigan, which is also beautiful.
It's the best. I grew up in Chicago. I
Oh.
love the lake.
Yeah, so here we've got that Midwestern thing going then, don't we?
Mhm.
Lovely. Well, we're gonna dive into a really fun conversation today about infertility or fertility. Maybe we should, pose it that way. But before we get into the nitty-gritty, I would like you to share with our listeners how and why you became a naturopath and what parts of that then pulled you into the fertility world.
Sure, great question. I was all set to become a more conventional doctor. I was doing my pre-med credits, and I had a professor that pulled me aside. He was an MD professor, and he said, "Grace, I think you should learn about this thing. I would feel badly if I didn't introduce you to this thing called naturopathic medicine." And he told me about it, and I learned about it, and it was the next day it was done because that approach to medicine just called my heart, and it really aligned with my values of not overtreating, believing that the body wants to be great, and eh, and and using the resources we have. And I'm certainly also a fan of conventional medicine, but the way I wanted to treat naturopathic medicine was certainly more aligned.
Yeah.
But in practicing, I did naturopathic medical school, I did a residency, I got into a group of a lot of just women's care, but I started seeing a big gap in the conventional medical system for these really engaged, smart women who were just falling through the cracks of conventional care. So if I could walk you through it,
Yeah.
if a woman isn't getting pregnant, she usually goes to her gynecologist, good first stop, and says, "Hey, what's going on?" The gynecologist is gonna run some tests, they're gonna follow protocol, the algorithm, totally appropriately. If those tests come back normal, then the woman is kinda shunted into this gray zone of waiting for eventually just keep trying, everything looks good, keep trying. And then they're referred finally, again, totally appropriate referral to a reproductive endocrinologist, so a fertility specialist. Now that fertility clinic is certainly going to lead towards IVF as the treatment.
Mhm.
But these women are saying, well, wait a minute. I'm not opposed to IVF necessarily, but why do I need it? My gynecologist said all of my tests were normal. I feel healthy. Why do I need this rather invasive, time consuming, expensive treatment when we don't have a diagnosis? And I saw that as a naturopathic physician, as a holistic provider, I really could fill that gap of explaining unexplained infertility and doing a root cause approach and finding out just why these women and couples haven't gotten pregnant, and then treating them and working with them.
Yes. So when you were starting out in your practice as a naturopath, were you working with allopathic MD doctors or osteopathic doctors or other naturopaths?
Well, I live in a small town. I was working as a solo practice. My um, uh, because I'm in a small town, we all know each other, the allopaths, the naturopaths. So it feels almost like we're all working together.
Mhm.
Plenty of opportunities there. But no, it was just me as a naturopathic doctor treating women for tertiary care. We don't provide primary care as naturopathic doctors in Colorado. So I was secondary and tertiary care for women who are like, I just want one person more on my team to help me figure out what's going on.
Yeah. So a lot of times, and it's interesting you mentioned about the conventional medicine and before the Flexner report in 1913, naturopathic style of medicine was the standard of care.
That's right, and you know that because you're an osteopath.
That's right. I am an osteopath through and through, just dyed in the wool.
It's
And
great because you're a real ally. I mean, our professions are more closely linked certainly
yes,
than naturopathic medicine and MDs.
right. Yeah, so for folks listening, MDs are allopaths, DOs are osteopaths, ND, N as in Nancy, D as in doctor, naturopath. And so it's very interesting because the Flexner report was really built around standardization, was built around, oh, I'm going to use the word control because that was in it. Politicizing of certain medical standards and marginalizing things that people just wanted to move away from and move more into pharmaceuticals. And that came out of the Gilded Age. And so there's some very interesting history and sociology around that. A.T. Still, who founded osteopathy in 1876, I believe that's the right year, was comrades with or compatriots with D.C. Palmer, chiropractic. And they went their ways, I'm sure, over a bone. They had a bone to pick with each other, no pun intended, right? And but A.T. Still also was more of a mystic. And I was drawn to osteopathy, and my, um, advisor at freshman year in college said, "You should be an osteopath." I go, "Oh, no, they're quacks. Nope, couldn't do it." And then here I am. Died
No,
quack, quack, here I come. So, not quacks, but
no, but we had to follow our callings.
exactly, root cause care. The body has the capacity to heal. Structure and function are inherently related, and then we're working to uncover that which we can support so the body can make its way, trusting its inherent wisdom.
Well said.
Yeah. So, all right. So diving into fertility or infertility, what should we call it? What's the better word of those two?
Well, they're both fine. There's fertility potential in everyone,
Yep.
and I treat infertility. So I'm happy with both. It doesn't offend me to talk about infertility. I know that's a tricky word for some women to say again and again, in which case we change the language. But when we're talking about diagnosing and treating, both are fine.
Yeah. Okay. So, and I think you described it pretty succinctly. And in my world, when I did traditional family practice, I did prenatal care the first few years in practice. And I actually strongly considered being an OBGYN because I was actually kind of good at it. It's kind of like a pilot. You've got, hours of boredom and then just a few minutes of sheer terror as you know, hopefully slippery little guys coming into the world, I'll tell you, or something happening. But what I found in that labor and delivery part was not only was there science, and if you look, honestly, if you look at the ACOG guidelines, they change all the time. And I think they change all the time because I think OB changes all the time because I think women change all the time. And
And the research is changing because a lot of the research isn't really made, like, about women.
right. Right. Yeah, even though that's women having babies, right? So go figure here. They're gonna let's soapbox this one in the right way, you know? And so those guidelines, and that's the pretty much the reason why I didn't become an OBGYN was because the guidelines kept changing. I'm like, that will just annoy me
Mhm.
because you're held to the guidelines more so in that specialty than any of some of the other specialties. And I think it's because there's two patients there, and I think that's why. But it was really fun, but I found a lot in OBGYN, especially the delivery stage, tons of intuition you needed to use to bring that baby into the world, and most of it looked and was a natural process at the end of the day for the baby and the mom.
Yeah.
So making that connection with those 2 was the most important thing, and then you could figure it out. And then, yes, of course, guidelines, and yes, of course, good care. But that's what I found most fascinating about the whole concept of labor and delivery and obstetrics. Um, anyway, so that's kinda my story, and so I always had a special interest in fertility as well because in my practice, women would come to me because they've been everywhere else and they were needing IVF and they said, "What if I don't wanna do that? You're gonna have to figure this out." That was the caveat. They would say, "Dr. Lauder, you're gonna have to figure this out." And I'm like, "Oh, thanks." So I did. But before I share some of my experiences, I really wanna hear your process of how you take a patient through this idea workup regarding fertility.
Sure. I think what's the most important piece is that we slow down and we get a diagnosis first. Not just the surface diagnosis, not just, okay, there's PCOS here. Um, we really go deeper and say, well, what else is going on? So getting a really strong intake, it's a long process. It's over an hour of just us chatting. It's a lot of forms to fill out, and then it's a lot of labs to do. We do a lot of functional testing, and the second visit, the deliverable is, I'll show you on the labs why you're not getting or staying pregnant. I'll give you a diagnosis for that unexplained infertility, or even if we have a good starter diagnosis, we're happy. We go deeper, um, and then from there we decide, okay, how do we want to treat this? Do you want to do IVF? Do we want to do this in a very conventional way? Do we want to integrate? Do we want to treat this completely naturally? In most cases, we can. And I think the other really important part about my intake is I rope the men in. Infertility, a male factor contributes to almost half of fertility challenges.
Okay.
There's this idea that fertility is a woman's problem. Pregnancy, that's a woman's issue. But fertility, by the nature of conception, it's 50-50, and it really does play out in like, clinically. For every 3 patients I see, and they're all women. I mean, I'm marketing to women, but a male has never approached me and said, "Oh, work up our infertility." It's always the women who are coming to me and saying, "Something must be wrong. What's going on with me?" And in one of 3 of them, I say, "Nothing." I mean, not of course, there's more we can do to improve your health, but this is a male factor infertility case. And
Mhm.
another one of 3, I said, "Both of you are contributing to this subfertility." And maybe 1 in 3, I say, "Okay, we're more focusing on you and your fertility." So bringing in really high quality testing for the males, I think, is another really important piece of my diagnostic process. But working with me, it's we diagnose first and then we treat.
Yeah, I think that's a great point, because you've mentioned the unknown reason for fertility issues, and then we jump right to treatment.
Mhm.
And that's really the paradigm in conventional medicine. Well, here's symptoms. We don't know why they're there, but boy, do I have a pill and or treatment for you.
Exactly.
And I just don't know philosophically where we went awry on that. Why that step of going back. Sir William Osler said, if you listen to the patient, they'll tell you what they have.
Mm.
When in doubt, go back and re-examine the patient.
Mhm.
If you aren't sure, take a history again. Those are the 3 things that I've built my practice on for 32 years. Never failed me. Never.
Yeah. And it's okay sometimes, right? We've got a headache, we take an ibuprofen. We never knew what that headache was about, but it was a 3-cent solution.
Right.
IVF, that's a $30,000 solution.
Yes.
So many women aren't willing or able to just go ahead and ignore the in between of, well, what is the diagnosis?
Yeah. So, what do you see as the leading cause for the unexplained fertility issues?
I think they're a handful. I'm not sure if I have a clear leader. I find a lot of autoimmunity. Standard workup of fertility is to test TSH only for a thyroid panel, and it doesn't let us know if there's Hashimoto's there. And I find Hashimoto's all the time, especially with secondary infertility. That condition will often flare after in a postpartum situation. So someone's already had 1 or 2 babies, and now they can't continue to grow their family. We usually find Hashimoto's, autoimmunity there. Um, Hidden infections. I had this great case last spring of a, do you mind if I tell it?
No,
Just kind
go
of run through
ahead.
it? Okay, great.
Yeah.
She had PCOS and a lot of insulin resistance. Her insulin was up at a 20 or something. We got her a CGM. She changed her diet. She was exercising. She's just doing so well. She lost a little weight. Her blood sugars came into normal. Her insulin got down to 8 or something. Um, but she still wasn't getting pregnant, and she always had this elevated CRP. We always knew there was inflammation there, but I assumed with the initial round of testing that that was, because of the insulin resistance. We retested mid case, and CRP was still high, even the insulin had really normalized or gotten much better. Um, so I was it was a mystery. Why is the CRP still elevated? And I was thinking like, gosh, maybe we'll run a GI map. Maybe we'll get into like, what could it be? And then on the next call we had, when I was about to tell her what we've got to do next, she said, mentioned something about being on antibiotics. I said, well, what was that about? She said, oh gosh, I had this infected root canal that I finally got fixed. And it was, I mean, I felt so silly because I didn't have anything about dental on my intake paperwork. So I missed it completely. I know that could cause systemic inflammation. And of course, I changed my forms the next day. But gosh, I was half mad at myself and half just excited for her because eureka, this is what's causing the inflammation.
Right.
My plan was to retest the CRP a month later, just to make sure that that was it.
Yeah.
And I didn't even get a chance to because she got pregnant the next cycle.
Oh, amazing. Yeah.
Yeah.
So, what you're saying is that root causes could be a root canal.
Ru Well, an infection,
Yeah.
absolutely, right?
Right.
Hidden infections, we're thinking about something in your gut, maybe an overgrowth of this or that, but, like an old, cytomegalovirus,
Yes.
like, right? Epstein-Barr.
Right.
Um, yeah, infections could be all sorts of places, but it was such a good example. Yeah,
Yeah.
teeth. Sure.
Exactly. So, and it's interesting because there's a lot of people that have, implants now when it gets to a
Mhm.
certain point. And even when the implants were put in, the bone didn't really take for a while. And it's because there's the infection in the bone.
Mm, mm.
And so, so if there so the key here is hidden something.
Yes,
And so
and
yeah.
And the labs, they'll call it.
Mhm.
If there's inflammation there that's not budging, you have to dig deeper. You have to find it. We can't just ignore it and say, "Huh, that just must be normal for you." It's not.
Right. Right.
So, yeah, autoimmunity, inflammation, hidden infections, toxicities are a big one, and luckily, they're kind of on blast right now. The women that I'm working with, the couples I'm working with, they're seeing that on their social media feeds, and they're learning that they shouldn't be using the nonstick pans, that they need to get the phthalates and the parabens and the BPAs out of their products and foods. So they're a little more aware. Sometimes I need to give a nudge about the scented perfumes and candles and whatnot. But those are, I mean, those are directly problematic to our organs, right? And they're also endocrine disruptors, so they're confusing our hormones on how to communicate with each other. So that's a big one, though I've noticed that I'm seeing a little bit less of that recently
Okay.
because
So
people are paying attention, not because they're less out there.
yeah. So what you're saying is things in the environment that interact with our hormones
Correct.
cause low-level inflammation, which can look even like autoimmunity.
Mhm.
And then as a result, that's because an endocrine disruptor means it looks like an endocrine, walks like an endocrine, but it ain't an endocrine. And it sits on a receptor because it's close enough to what an endocrine looks like. And so when it sits on that receptor, that message of "Hello, Sam" turns into "Go away, Sally," and nothing is communicated or the
Mhm.
wrong message is communicated, right?
Yep.
So how did so I guess I'm sure that maybe other people ask this question, but why do you think this isn't looked at when it's in our culture, that in terms of the toxicities, and we know about we know about some of the pans with the nonstick coatings, and we know about chemicals in the air and the coal factories and, the power plants. So why is this, do we, where, because where does that come from that we just don't pay attention to this? What are your thoughts about that?
Well, these plasticizers, these chemicals have been are invented and embraced because they make life easier.
Hmm.
They make us smell better. They make it easier to cook our food. They make us have to do less dishes, right? It makes sense that we've integrated them into our lives. And I think when they first were introduced, we didn't quite realize the impact. And now we do, and we're a little like, "God, I have to pry it out of my fingers. This really makes my life easier." We're so used to easy now. We've gotten right? As a species, we've gotten a little soft. So I think it's hard to reverse that once you've had a taste, but it's certainly worthwhile.
Yeah. Do you think have women come to you and in their, gynecological history had really heavy periods, a lot of dysmenorrhea, which is painful periods. The heavy period would be menorrhagia, the heavy frequent periods where the cycles are shorter. Instead of 28 days, it could be 21 to 25, and they're slightly irregular between, 23 to 32 type thing, where they've got a history that if they look backwards, things weren't always easy in the gynecological aspect of their life.
Sure, and that's one of the first things I start with. I say, "Give me the timeline of your fertility tale," meaning what have they tried? What have they done? What have they already been through? And then let's talk about how your cycles present because those details are make it so much easier for me to dissect the case and knowing those bleeding patterns and also helping them realize like a flooding period for 3 days is not normal and we can get to the bottom of this. It's probably too much estrogen, maybe it's not enough progesterone, maybe it's the toxicants, could be something else entirely, but there's so many clues in the menstrual history, that's where I spend at least a third of the visit the first time I meet with a patient.
Yeah, and I think there's an aspect to the menstrual cycle that has a, soul implication and a spiritual implication.
Oh, tell me more.
Okay, so you've got this 28-day cycle of life to death, right? So the egg is made in the ovary, it matures, it, ovulates about day 14 to, 16 to 17, 18, and then it waits for, fertilization. If not, there's no implantation, and so it leaves, as does the lining of the uterus, so that's a death. Men tend to cycle, like, in a 24-hour period relative to their testosterone. Women, it's a 28-day period. Women endure much more in that cycle of life to death than men do day to day. And so we carry things, we hold things, we nurture things much longer. And I've often thought that as because I've been through menopause now for quite a number of years, and so looking back on things and seeing things is that perimenopause is kinda like a protracted period. So if you take your entire menstrual history as one period, then you put perimenopause in there, that's like the PMS stage.
Alright.
And then you hit
Sure is.
then you're kind of, it's over. Or not menstruation, but menopause, it's over. And so and how hairy is menopause? Well, let me tell you the ways, right? There's so many ways that is. And so it's the same thing. It's either 28 days or it's this lifelong cycle. And I submit that if now knowing and seeing and living that it's the same thing as protracted as it is every 28 days. And so I can predict who's gonna have struggles with perimenopause and into menopause based upon their monthly cycle patterns.
Oh, that's so interesting.
Yeah.
And I like the way that you broke that down, and I guess I'm gonna take it further in that I think this is what you were saying. We have 28 days, we have our full cycle for that egg to really absorb the world around us and the experience we have. And for men, it's shorter. I've read a study it was a correlative study. It was certainly not causal, but there was a correlation between the stress state of the man at the time of conception and the anxiety later in life in the child.
Yes.
It's so interesting.
Yes. And there's it and some of that comes down on the DNA. That literally changes the single nucleotide polymorphisms or SNPs. And it influences how the SNPs present one to the other. 23 from dad, 23 from mom, 46 reasons you need to go to therapy. So S
Yes, ma'am.
Thank you, dad. Thank you, mom. Here we are. So, and so we see that, and so if we've got that stress on those genes, that then comes into, well, there is a microbiome in the uterus, in the endometrium. There's a microbiome in the bladder. There's a microbiome in a joint. There
That's a test I've been loving, is testing the microbiome of the vagina.
Yes. Yes. And so, none of that is, um, none of that is, what was I gonna say? None of that is by itself, but it's all together because it's got 2 vaginal microbiome, got 2 uterine microbiome, got 2, liver. And one of the things, have you seen where we used to have tests in the olden days, functional medicine, of the liver pathways, where they would give them caffeine and acetaminophen, them being the patient, and then you would do a urine test, and it would excrete through the cytochrome P450,
Sure.
phase 1 and phase 2. I don't think those tests exist anymore. If they do, I can't find them. Um, and we could really get a good idea of phase 1, phase 2 of liver detoxification. Then you've got kind of the 4 steps in phase 2 with the sulfation, methylation, glucuronidation, after the cytochrome P450. Frankly, I think that's where the action is.
Absolutely, those tests would be super handy. I think the Dutch has kind of replaced that in terms
Yeah.
of breaking it down, but cortisol is stress hormone is broken down through the same pathway. If someone can't tolerate their coffee in the morning, they're not going to be able to break down that cortisol any more efficiently. Yeah, let's bring those back. That sounds good.
Yeah, I think it's interesting because that's where the action is. And so my foray into infertility was because people would come back and say, I don't want to do that. What are you going to do for me? I'm like, oh, I don't know. So I had to figure it out. Right. And that's how one of the reasons I got into really truly functional medicine is because people kept coming back after going to specialists. And so what I found is I did liver detoxification.
Yeah.
And I followed protocols that had been curated that had clinical, science behind them. Are they double blind, placebo-controlled studies? No, because that doesn't exactly have to be that way. You can do observational studies, you can get the right data a few different ways. But we had the results where we were able to do before and after tests and see the improvement in the pathways. And then when we put the genes on there, the genomic aspect, COMT, MTHFR, I'm gonna MTHR, I'm gonna die with it, not from it. Let's go, move along here, nothing to see, right? It's not a one gene does a disease make.
No, but taking the burden off, and also, I mean, you're doubling down with if we're getting the toxicants out while doing the detox. I start almost every patient with a detox, whether that's because I see that their estrogen's too high or their toxic burden is too high, or because we're living in toxic places, and we all kind of need it if it hasn't been done in a while. But that's epigenetic piece is very critical as well.
It is. Have you had patients come to you that have said, um, I'm trying not to laugh, but it is kind of funny that I'm intolerant to my progesterone. I'm
I have.
progesterone intolerance.
Yeah.
I think I mean, I'm gonna pull the gender card in this one. My hunch is a guy made that one up. And throw me
It's
under the
like,
bus.
it's really not possible because you make it. What I've seen is really poor outcomes with taking exogenous progesterone, right? Taking an oral progesterone or a vaginal progesterone that the symptoms really bloat, and bloating being one of the symptoms, but,
Yeah.
uh, yeah, progesterone intolerance.
Yeah. Well, hello, it's liver.
Right.
That's all it is. You've just gotta clear the pathways.
Yes.
That's it. It's really, and it's like and I think because I've done that for literally 25 years in people, like, "You guys, it's just right here." "Well, no, I'm intolerant to it." "No, no, no, no." If
No,
you
there's a backup.
to progesterone, you'd be dead because it's really in your body anyway. It's
You make it every month.
you put some in you that you try to metabolize it. It just points to the fact that your metabolism of it is imbalanced.
Correct.
Yeah. And same thing with estrogen dominance, which is really PCOS, polycystic ovarian syndrome. There's really some nice genes and eloquence around that relative to insulin sensitivity.
And
Also,
it's what drives that PMS stage, and if we wanna, like, zoom out, that perimenopause stage.
yes,
It's all that extra estrogen dancing around that's making us really feisty.
it is exactly. And then it drops, and then because it drops, where did it go? It's still there because it's in the adipose. So then
Right.
we got the toxic estrogen stores there. Yeah. All right. So what simple things can people do today? Say, "Hey, this sounds like me."
Mhm.
Okay. Maybe I've already had my children, or maybe I am struggling with fertility, or maybe I'm planning to get pregnant. What can I do to make myself the healthiest possible?
I think, again, we wanna use diagnose and treat, and I'm happy to give lifestyle choices that I think are best for fertility, but the first thing I would recommend doing is track something, whether it's cervical fluid, whether it's your temperature every day. There's such cool tech out there tracking the metabolites in the urine. So the brands out there are Mira and Anito and Uva. I'm forgetting one, where you can do urine strips daily at home
Okay.
and see just exactly where your estrogen is throughout the cycle and what your progesterone is doing as a response and exactly when that LH surge is. I've had patients who have been in the timeline, right? They went to their gynecologist, they've waited a couple years. Finally, they're sitting with me, and nobody ever said, "You're not ovulating." And they'll say, "Well, yes, I'm having my LH surge." And I said, "Well, that's just one domino, right? The estrogen rises, and that triggers the LH surge. The LH surge tells the ovaries, go ahead and ovulate. But until we have a progesterone value 7 days later or an ultrasound, we don't know if they ovulated." And that can be missed because I can't tell you how many gynecologists have said to me, how many I shouldn't say gynecologists, how many physicians have said, "If you're menstruating, you're ovulating." It's not true. It's not true.
Nope.
You can bleed from just a estrogen come down. So I think tracking and making sure that you're ovulating when you think you're ovulating, you're timing your intercourse correctly around that other signs of fertility really match up. I love tracking cervical fluid, and it sounds, it's cervical mucus in the literature, and that sounds a bit daunting and yucky, but it's it's really neat. It's essential for getting pregnant. It has very good, I always flip around specificity and, um, my statistical terms, but
Sensitivity. Yeah.
there it is.
Yeah.
If you don't have egg white quality, this great quality cervical mucus, you are not ovulating. If
Okay.
you do have it, there's an 87% chance that you are ovulating. So it's really great to gauge, am I ovulating or not? Am I making the cervical fluid? Um, Temperature tracking, basal body to temperature tracking, I think is great. There's again, gadgets, like the tech is fun. There's a product called Temp Drop on the market. You put a band around your upper arm every night before you go to bed, just to make it a little bit easier. But those fluctuations in temperature can tell me a lot about when the LH surge is happening, if the progesterone is coming up quick enough. So tracking something, I think, is a really good first recommendation. And then doing an inventory of the foundations: diet, exercise, sleep, stress, right? What are those are critical. We can't build our fertility unless we've got those secure. So making sure you're you're moving and that you're getting your 10,000 steps a day. And if you haven't started weightlifting, now's the time. It's your time. You're ready. It's time to do it a couple times a week. We don't have to run marathons. In fact, maybe we shouldn't if we're trying to get pregnant or struggling to get pregnant. It doesn't need to be hit workouts, but we need to move our bodies. We need to engage our core because that's just a massage on the ovaries. The more that happens, the more circulation we get, the more nutrients they get. Um, so yeah, exercise. The dietary piece is the most research is the Mediterranean diet. So that's kind of the
Yeah.
steady recommendation.
Yeah.
Follow as close to a Mediterranean diet as you can. But are you sleeping well? And are you managing your stress well?
Mhm. If you're in fight, flight, fawn, or freeze, good luck, right?
You're not going to make a baby.
Right.
And that makes sense evolutionarily. You're not in a place to.
Right.
We have to activate the parasympathetic nervous system. We have to rest and digest and, you know, populate.
Yes. Yeah, and really have time to have that, intimacy, and you've gotta be relaxed to have it.
Mhm.
How many, stories can you share that I also could share of where, somebody went through fertility treatment, got pregnant, or they adopted a little baby, and then, 3, 4 months later, they're pregnant.
You're pregnant. Yeah. Absolutely. And I think that's where that age-old wisdom of just relax, yeah, stop stressing about it and it'll come. Like, yes, we've all seen that play out, but to my God love them, my type A patients, like that is not a helpful piece of advice.
Yeah. So what I'm hearing is the look at your environment.
Mhm.
So look at the things around you, the things that you use to cook with, the types of food you eat, how you eat them, what your work-life balance stress is, what your relationship status is. Are you settled with where you wanna be and really, ready to go? Are you nesting, right? And then, look at, things that could have happened in your history. This unexplained virus in college that just you didn't
Mhm.
quite kick the fatigue with. Do you have maybe did you get a tick bite you're unaware of? 'Cause all the nymphs can bite, the little teeny tiny nymphs that you can't see.
Oh, good grief.
Yeah, and so, not fear here, but just like if there's still the markers that come back.
Right.
And then if you go to your physician, whoever you see, and they don't do the inflammatory test, they don't do the full thyroid panel, request it. Be it.
Yeah. You have to advocate for yourself.
Yeah,
And I know that's hard and that's a silly system. It's not ideal, but the squeaky wheel gets the grease. And I did read a research paper a while ago that said difficult patients get better care.
yeah. And that's it's unfortunate that I think is an implicit bias. And
Oh yeah,
I think um, I think that's just wrong. I
absolutely.
I mean, I've always also maintained patients, how do you know what they have? I said, well, they can have whatever they want. Meaning we could diagnose them with anything. Well, who knows what it is? Well, it couldn't be that. Well, how do you know? Right. And so I think it's just super important to listen. And if somebody feels that there really is something, go searching for it.
Absolutely. And there's plenty of places you can self-order these tests. I mean,
Yeah.
it's again not ideal to be ordering blood work as a non-healthcare provider, but here we are,
Yeah.
and you can access it if you want it.
You can. So I think, let's see. So what do you think are if someone's been struggling for years, because I imagine folks might find you that way,
Mhm.
uh, middle of the night Google search, yeah, the urgency is high, some, and so what would you say if someone's been struggling for years but they maybe they had barriers to the IVF, you know? Either how they felt they didn't wanna do that or financial barriers. Um, what would you say?
Well, first, I'd assure them that we all have this idea that IVF is this safety net at the end of our fertility journey. It's really not. The outcomes, especially if you're like 40, I work a lot with women who are between 40 and 44. Their outcomes aren't that great. I mean, it's like 5% chance that we'll get it on the first round.
Okay.
So I assure them that just because they decided not to go down the IVF road doesn't mean that they've made a terrible decision.
Yeah.
And the second thing I do, and it's hard for them to understand this and commit at the beginning, but it's so important for their mental state, is for them to take a break from trying, for them to purposefully avoid having sex during their fertile window while I do the work, while I get the diagnosis, and while we start treating it. Because there's no disengaging from the stress of having a period of that we call the 2-week wait, right? So when they've tried, they've day 14, they've done everything they can, they've had great sex when they're ovulating, everything lined up, and now they just wait. And if they're like most of us, they have a few PMS symptoms that unfortunately overlap pretty well with early pregnancy symptoms. So every little twinge, every little nausea, every little feisty thought, is it, am I pregnant? A little bleeding. Is this implantation bleeding or am I losing a pregnancy? Is everything causes stress. And unless you say, don't try, you are not pregnant this cycle for a few cycles in a row, it's impossible to disengage. The men kind of like they do their job and then they're out of it. I mean, they're also like anxious to find out if it's a positive pregnancy test, but they're not in it every minute
Yeah.
of those 2 weeks. And that roller coaster can just be devastating. It's also really hard on couples' sex lives to be trying for this long. I
Right.
mean, the sex loses its luster.
Mhm.
So taking a break from trying is a really nice reset for both parties. But especially I think the women that just carry this burden
Yeah.
cycle to cycle.
That's really good advice. And I think too, to remember that, fertility and infertility can also include couples who've had miscarriages
Mhm.
and the unexplained miscarriages.
Yeah.
In this day and age, they shouldn't be unexplained.
Right. We have plenty of tests, and it's too bad that we have to wait for 3 losses to get the recurrent loss panel.
Yeah.
Don't make them go through that 3rd loss, just run it on the 2nd one, right? They estimate 1 in 5 pregnancies end in a miscarriage just based on, chromosomal it's
Mhm.
they're not compatible with life. Um, but if you have 2, let's test. Let's work that up. Let's not put you through, God forbid, a 3rd loss. Let's make the next pregnancy the baby, right? The full-term pregnancy.
Yep.
Yes, it's all in that umbrella of infertility, getting or staying pregnant.
Yeah. Great. Well, wise words to our listeners. Thank you. It's
Ah,
been
thanks.
absolutely delightful to talk with you.
Yeah, this has been really fun.
Yeah.
We have a shared soapbox, it seems.
We do. We do. And what's really fun is that you're accessible to folks. So we'll put in the show notes how to get a hold of you. You're in Steamboat Springs. Of course, they could take a lovely trip to Steamboat.
No, come visit.
But also, you're doing telemedicine and telehealth and teleconsults and
That's right. I learned during the pandemic that I can do my job entirely tele. So that's
yeah,
what I do.
wonderful. And so we'll put all that information so that they folks can find you. And I
Great.
think um I I fully endorse you. I mean, I just think you've got a handle on this. I think you not only have the, patient at heart, but you've got the niche that
Appreciate
I
that.
think is the right spot to really help a lot of people that are seeking answers. Because really the answers lie in the things that we can find functionally. Because if the structure looks normal, you got to look at function. That's the functional test.
Yep.
And so that's you, that's your job, and that is your passion, and I think I'm just so thrilled to meet you because I think you just do it wonderfully. So thank you for all the work that you do for your peoples and your families and your couples.
Oh, thank you, Mary. I so appreciate this.
Yeah, it's really wonderful. So that's I and you really Dr. Grace, there you go, full of grace. Well done, well named, says Saint Mary over here. So we're a pair, I'm sure. So thank you for your time, and I appreciate it very much.
Thank you, Mary.
What a gift to hear Dr. Grace Charles today speak with such clarity and care about fertility as more than a clinical outcome, but as a whole person journey. If something she shared today offered you new insight or eased a burden you've been carrying, I hope that you'll just let that go and hold on to the hope that there is help for you. Let it root, let it rise, and reach out. Please rate and review the podcast wherever you listen, and let us hear from you if you have any questions or feedback. Thanks for listening today, and be well. See you next time. That's a wrap for this episode of the Dr. Mary Louder podcast show. I hope you've heard something today that made you think, laugh, or say, well, now that was a plot twist I didn't expect. Just remember, your health journey is more than lab results and supplements. It's spirit, soul, and story, and sometimes a gadget or two you probably should have returned. If you enjoyed the show, please rate and review us wherever you listen to your podcasts. And please share our podcast with someone you love. If you didn't like the show, well, maybe don't tell anybody then. And if you want more soulful medicine, curious conversations, and tools that actually help, visit me anytime at drmarylauder.com. Until next time, stay kind and stay curious. Music today is provided by Mr. Dave Evans. He composed, played, and engineered this song specifically for our podcast, and it's called Soul Strings, an acoustic reflection of the healing path. Thanks, Dave. It's great music.